All right, so EMS is called to the unconscious. Upon arrival, a 45-year-old male patient is found lying in a pile of leaves alongside a park path. The patient was participating in a 5-mile running race when he suddenly collapsed. The patient is unresponsive to painful stimuli and is visibly diaphoretic. The patient's sister is on scene and states that she was running with him the entire time. The patient is moderately overweight and was recently diagnosed with prediabetes and hypertension, prompting him to decide to start getting in shape. The patient's sister states the patient had not participated in a significant amount of physical exercise prior to this event and did not do much training in preparation. So for history, you have prediabetes and hypertension. Something is blinking. He's taking carvedilol and metformin, and he has no allergies. Initial vitals are 90/50, respiratory rate of 22, rapid and regular, a pulse of 180, regular. SpO2 is 98% on room air. So if you look, this is what you get on the life pack when you do a 3N12. So, what are some of your differential diagnoses?
Unstable angina.
Okay.
Or stable. I don't remember which is which. I think one is brought on by exercise, right?
Yes. So one is brought on by exercise. Well, stable angina is brought on by a specific event and then goes away in like a regular amount of time. Unstable is like that event triggers the same kind of chest pain, but it just doesn't go away. So I'll even do like let's narrow broaden it a little bit to acute coronary syndrome. What else?
Oh, SVT.
SVT. All right, it's good. So what's your rate here?
Rate is 180, and he's almost, I guess, 90/50. He's still. Would that be considered hemodynamically unstable, 90/50? Well, I mean, he's unstable because he's not responsive. But
good. So let's go. Let's put reasons he's unstable. So reasons he's unstable. So one, he has a borderline blood pressure. I'll give you the borderline. Like you can go either way with a 90/50.
Okay.
He's AMS.
Yep.
What else? What else would you like look at him go, not the stable?
Cool pill. What is it? Diaphoretic.
All right. So one thing though, he was just outside running.
Mm-hmm.
So when he's visibly diaphoretic, this is one of those things where you kind of now need to take your environmental concerns, right?
Okay, true.
So if he was outside and he was very moist, but it was raining, not concerned. But if he was outside and it was a hot, humid day and he was running for an hour, you might expect him to be diaphoretic. A cool day with a gentle breeze and he's visibly diaphoretic, a little more in terms of like being concerned about why that is. Good though.
So possibly heat stroke.
Good.
Depending on the weather.
Good. Heat stroke, right? Is the SVT like the chicken or the egg?
Mm-hmm.
Anything else that you'd want to consider?
Sorry.
Hypoglycemia.
Hypoglycemia. Perfect. I heard BGL in the background. Right?
He was just, I think carvedilol, that's a beta blocker. So if he was recently put on it, that could have something to do with it as well.
Okay, I think I think if you had him, if his heart rate was very bradycardic, then
Brady,
absolutely,
okay.
yeah, absolutely, the beta blocker would be a concern. All right, so these are good. These are all very good differential diagnoses. Now, what protocol, or what is something like? Let's go with vital signs. So I heard. So we wanted to get a BGL, right? What are some other things that you might want to include as part of your assessment? So let's put the assessment over here. So you have a 3 lead. You have a 12 lead. The BGL was requested. What else, guys? You have an SpO2. What other things do you want to add?
Well, I mean, I'd also be worried about trauma as well because he's found unconscious. Some of it.
Okay. What would you do to deal with the trauma?
I mean, I'd consider C-spine.
Good. Maybe a head to toe?
Yep.
He suddenly collapsed, though.
Yes.
Maybe, okay.
So keep going down that rabbit hole. He suddenly collapsed. So what? What do you want to do?
I mean, if he suddenly collapsed and we find some trauma, all right. So he may have some trauma from the fall at a standing height, but what caused him to collapse? That's the thing. What?
Well, he's also unconscious, so we got to worry about his airway.
Good. Yes. Let's.
So do ABCs.
We're gonna come. Thank you, Roger. We're gonna come back to the trauma thing in a little bit, Joni. All right. So with ABCs, right? So if his airway's patent, what are some of the things you want to do? Shut up. If his airway's patent, what are some of the things you want to do?
Is he accepting an OPA?
Perfect. OPA. Don't forget OPA. He does not accept an OPA.
I just put him on a breather.
Okay.
His respiration are 22 and he's setting at 98.
Okay, good. What else? How about your circulation?
If his heart rate, it's very fast, and he's diaphoretic.
Mm-hmm.
I don't know if it's weak. Maybe it is a fast heart rate though, so you still want to check his radial pulses, see if they're present.
Okay,
True.
good.
His distal pulses, peripheral.
Okay,
pulses.
so if he has
See how they
no distal pulses,
Mm-hmm.
how is that going to impact how you treat? What are some considerations?
We're treating him for shock.
Treating for shock. Good. What are your treatments for shock? Your basic
warming,
BLS.
keeping warm, oxygenation.
Good. And positioning. Yeah, right. Positioning. All right. So let's talk now a little bit about the trauma that we had mentioned. Is it possible that he was struck by something and that's what caused him to collapse?
It's a possibility, but if you have witnesses, you would obviously talk with them, see what they witnessed. If she was running with him,
Good.
then you have pretty much your answers right there.
Good.
And how did he collapse? Was it forward or back, to the side? Did he just go down to the ground from like legs giving out?
Yeah, like full on bag of potatoes, boofed into the side. Exactly. Now, let's talk about treatment for this a little bit. How do we want to treat this?
But wouldn't we suspect that his heart rate would be elevated secondary to the race? Is that, I mean, I wouldn't completely cancel that out because I don't know if he's in SVT. You know, I don't
Perfect.
If he didn't exercise and he's not properly managed for this race, it sounds like his body would be overworking as well and find him to have a high pulse rate secondary to the race.
How would you fix that?
You got to fix the heart, because this is some form of cardiogenic shock. I don't know if you would want to give this guy fluid, because then you would just overwork the heart more.
So this is one of those, like, do you give him a fluid bolus and see what happens? Right? 250, he's 45. Like, it's not like he's like a 90-year-old guy who like decided I'm going to go jog today. You know, he's presumably relatively healthy. Right? Like, he's like on that, like the better side of 50, where if you were like, let me see how this fluid goes, you'd like wouldn't necessarily expect it to end up in his lungs. Like, if he was on the other side, you'd be like, lungs are an issue. But he was just running, right? So if I said, oh, he's at like mile 1 versus he's at mile 4.5, how would that change how you feel about giving him fluids?
Okay, he's probably dehydrated.
Okay, right? So let's rule out severe dehydration. And that brings you back to your environment, which no one actually asked about.
What's the environment like?
So, it is a clear, crisp autumn day.
Mm-hmm. How's he dressed?
So it's an autumn day. He has a t-shirt, a sweatshirt, and sweatpants on, which is all probably temperature appropriate. It's not humid.
Okay. All right. So at this point, would we have given him the 250 milliliters of fluid, IV bolus, and what's going to happen with his condition now?
Yeah, I was going to ask what's after our assessment or reset of vitals.
All right, good. So you gave him a 250 milliliter bolus, and his vitals are exactly the same. Nothing has changed, but his lung sounds are still clear.
Mm-hmm. Mm-hmm.
Also, sidebar, what size IV are y'all wanting to put in? Joni, we talked
18.
All right, so Joni and I talked about this a little bit the other day. So it's 14 gauge versus a 16. Both of these are appropriate. Large bore is very good for this kind of
He's
patient.
wide open.
But the only thing that you have to take into consideration, and it's going to sound really stupid, but you actually will get more. So if you imagine, so a 14 gauge is probably about the size of a coffee stirrer, right? So imagine that's a 14. And then a 16 gauge is about the same size. Now a 14 gauge is about 1.75 inches long, whereas a 16 gauge is 1.16. And I literally only know the exact numbers of this because we were talking about this the other day. Now, a 14 gauge, if you think about the size of the catheter that's going to be in that patient's arm, this entirety of this catheter is going to create resistance for fluid flow. So if you have two bore IVs that are pretty identical in terms of size, but you have one that's shorter, you'll actually end up getting more fluid in with a 16 gauge. For those who are like firefighters, right? You know, a shorter hose with a larger bore is going to be faster than a long hose with a smaller bore. So it's all about surface area tension. So a 16 or a 14 is appropriate for this patient.
He's exactly the same. Okay, so if he's still exactly the same, I would start leaning more towards that his heart rhythm being the issue.
All right.
I would start going more towards Edison.
Two options, medicine, Edison, right?
Since he's still not stable.
All right, so before we go to Edison, which is the appropriate treatment for this patient because he is over here, as we said, unstable, what's your medication that you're going to use and your dosage?
Adenosine.
Good. How much?
6 milligrams to start with a rapid push and 10 cc's to follow.
Good. What's your second dose of adenosine if that doesn't work?
12 milligrams, also followed by a flush.
Okay. And I do believe the collaborative protocol you have does not allow for a third dose of adenosine, but if you do have a third dose, it's, again,
another 12.
Another 12. Now, since we already spilled the beans that you would like to actually... I'm running out of good colors. That's so depressing. All right, so Edison is the most appropriate. What is your dosage for your Edison?
Start at 100.
100. Okay, good. To what?
Then go up by 100.
So 200. Then what?
300, and then the max, I believe it's like 360 for the what is biphasic? Biphasic?
In general, yeah, it's 360. You're gonna barbecue a little heart muscle here at the 360. All right, so are you going to need to sedate this patient?
Patient's unconscious.
Perfect. Okay. No, there are medics out there who would try to sedate a dead body. Seen it. So, so you deliver 100 joules.
Okay. Synchronized cutter. Right?
Thank you. Perfect. Make sure you sync. Always sync that. And the patient reverts right back into a SVT at 180.
Mm-hmm. After 100 joules?
Mm-hmm.
So we bump it up to 200.
Okay. Patient still, it's like, it heart just ticks right through like you didn't even do anything. Still a solid 180.
Fuck. 300. Shit.
Keep going, following up the ladder until we get to 360.
Okay, cool. You make it all the way up to 360. You shock him at 360, and it still doesn't do anything. His heart continues to tick at a SVT at a perfect 180 on the dot. What do you want to do?
Mm-hmm. Call med control.
Consult med. Yeah.
Yes. So, medical control. Always remember that that's an option. You get Dr. Hedge, and Dr. Hedge goes, "Oh, I don't know. Shock him again, and then go to the hospital. How far are you from the hospital? 5 minutes from the hospital. Go to the hospital. Drive fast. Be safe." That's relatively close to what he said.
He wouldn't say like, all right, you shocked them all the way to 360. Let's just give a adenosine and see what happens. They wouldn't do that.
No, he didn't. He said to shock again. So real life story. Ended up shocking him at 100 and was like, it just ticked right through. Like it didn't even, when you do like a defibrillation and you get that like that pause, that little brief pause. It's like just an isoelectric line. It didn't even do that. It just kept going like I never shocked him. So I'm like, this isn't cardiac. Like there's something, like my gut was telling me there's something like totally not cardiac about this. So I called and I was like, "Hey doc," and he's like, "Hello," and I was like, "I don't think this is a cardiac SVT." And he's like, "Where are you?" And we were in Forest Park, and he goes, I'm like, "We're at Forest Park." He goes, "How far from the hospital are you?" I'm like, 5 minutes. He's like, "All right, I'll let them know you're coming. Hit him with 200 and go to the hospital." And he goes, "Just give him fluids." And I was like, "Okie dokie." So I believe we got a 16 and a 14. We pumped him full of about a liter of fluid between the two arms. Hit him with the 200, ticked right through, like there was no pause. His heart just kept going like it was absolutely nothing. Actually, I can stop sharing for half a second. By the time we got to the hospital, he was ANO2. SVT still. We brought him right to chest pain in Jamaica, and they're like, "He's AMS, code stroke," and I'm like,
What the fuck?
I don't think so, but I see like the CYA of this whole scenario.
I get you.
Yeah. So they hung another liter bag because he was still hypotensive. Sent him to CT. When he got back, he's ANO3. And he's like, "I don't remember what happened. I don't know what's going on. I have no complaints. I just kind of feel a little weak right now. But, I just ran 5 miles, so, like, I feel like that's probably normal." Turned out that he had severe rhabdo. And
wait, what's the rhabdo again?
Rhabdomyolysis. So basically the extreme exertion that he put himself through with zero training, he broke down his muscle cells and released all sorts of myoglobin into his bloodstream.
Oh shit.
And he ended up with like a level 3 kidney injury. And he ended up ultimately getting, I think, 8 liters of fluid to flush his system out. Roger, you're barking at a door. So, all in all, it was a very interesting call and very much like one of those things that I was not expecting. Like your gut's telling you, like, I really don't think this is cardiac. Like, it didn't walk like a duck. So, and Dr. Hedge was not the most helpful, but he tried. So yeah, just remember, every once in a while you do get a zebra. Fluids are not a bad thing.
I thought myoglobin could only be released because of the compartment syndrome from what we went over.
No, so you'll also see in CrossFit athletes. It's very common in CrossFit athletes because basically they'll go and do this like super intense workout that their body's not prepared to, and they just actually, instead of like building muscle, they break the muscles down. And once you start causing like real damage to the muscles, it will cause rhabdo. So basically, it's anyone who's underprepared for the athletic activity that they're participating in.
Mm-hmm.
Ow, hi.
Is that like? Is that like that lactic acid burn you get when you're working out? Is that like a mild form of that?
It's, I want to say, like the beginning. So if you think about how, as you exercise, right, the first thing is like your muscles start Stop typing on that, please. Thank you. The first thing that happens is that your muscles are in aerobic exercise, right? So there's an adequate amount of oxygen. You're getting a little sassy there, buddy. There's an adequate amount of oxygen to maintain the muscles' metabolism. As you continue, and as you, then as you continue burning the glycogen in the muscle, and you start overexerting the muscle, it switches to anaerobic, and that's where you start getting that lactic acid and getting that lactic acid burn. And then as you continue forward, as the muscle either fatigues and you hit failure, or you push the muscle and actually kind of cause it to explode, and that's where you get the rhabdo.
Gotcha.
That's my toes you're biting. So that's what I got for you.
Nice. You know, to be honest, if that was one of my first calls as an actual medic, I'll be a little nervous. After I was like, okay, all right, cool. So what I know is he's hemodynamically, well, he's unstable. Gotta go Edison. I do the cardiovert, nothing happens. Do it again, nothing happens. I was like, oh shit, now I freaking fried this guy for no reason, because it wasn't this. This wasn't the treatment plan for him.
Yeah, but at the same time, like, so the two, you have three courses of action, right? You have your fluids, you have adenosine, and then you have electric. So in the grand scheme of things, you didn't do anything wrong by the patient, because you've provided him with a fluid bolus, and you chose the appropriate pathway for the cardiac rhythm that he was in. Again, you have that chicken or the egg. Is it the heart that's causing the problem, or is there a problem affecting the heart? And sometimes you're not going to know those things. You're not going to get the answer to that until, they're in the hospital and they're doing all sorts of blood draws on them. We don't have, the point of care testing for some things that that could be useful.
Okay. But
yeah, a little bit of a fried heart. It definitely did not help his existing rhabdo. Just a little sprinkle on top. What's that right there, little heart?
Give him the fourth best medication, diesel therapy.
It's true.
That's it.
It's true. That and the terrified medic student. Definitely had a medic student. She was like, "What's going on?" I'm like, "You don't have to freak out. It's okay." She's like, "But," I'm like, "You're gonna get to cardio for today. This is a great day." And she's like, "This is true." I'm like, "Hit the button." What is going on? Hi. Are you here to learn?
Would pre-workout do something like that too?
It depends what kind of pre-workout. But has the
not really the rhabdo, but more of the SVT.
Yes, I will go to your room. Yes, it can potentially cause dysrhythmias, because some of those pre-workouts will actually pop you on a drug test. Some of them have very high levels of things like taurine or caffeine, and if a lot of people don't just do pre-workout, right? It's pre-workout and a Red Bull and maybe a Monster 2 hours ago and maybe a cup of coffee. So, and what other stimulants are you on? Like, oh yeah, no, I take this like fat burn thing, and it's like full of other stimulants. It can absolutely cause a really delightful cardiac dysrhythmia.
For that patient, we should be starting with a liter bag for him.
Yeah.
Okay.
Yeah, that's somebody who you're starting 2 large bore IVs and hanging them, and maybe one of them you take a blood pressure cuff out and give it a little squeeze.
Yeah, okay.
Cool. Any other thoughts, questions, or concerns before we make Joni type really fast?
Yeah, Joni, sorry I don't text fast. My bad.
All right.
Your pre-workout will help you.
Yeah, a little pre-workout. Get that heart rate up. Had another interesting job with Emilio the other day. Actually, we had 2 really good jobs. We had one lady who was she called because she like wasn't feeling well, and we got there. I'm like, what's going on? And she's like, this really sweet little lady, and she's like, my face is pulsating, and I was like, that's a new one. I'm like, okay. When did that start? She's like, it started like 5:30. She's sitting with her arm on the table and her arms out like this, just perfectly like knife hand flat. And I was like, okay. But she had the blood pressure cuff on. I was like, oh, like, are you sitting really still to take your blood pressure? And then she's like, can you do me a favor? I'm like, sure. What's up? She goes, can you put my thumb back? And I was like, what do you mean? She goes, my thumb. Her hand was like this. She goes, I can't move my thumb. And I was like, how's that? And then it just started going back again. I was like, all right, cool. So I'm like, all right, so what's going on? Well, I felt like this the last time I had a stroke. I was like, oh, good.
Wow.
Delightful. We need to go to the hospital. And she's like, I don't want to go to the hospital. And I'm like, you have to go, sweetie. And she's like, no, they're going to poke me. I don't want them to poke me. I've got hard veins to find. They're going to poke me. And I was like, but good news, we're not going to poke you. We're nice. Like, we'll take you to the hospital. Go get you checked out. She's like, I'm not going to Jamaica. I'm like, shock. Let me guess, 35? She's like, yeah. Like, can we go to North Shore? I'm like, I don't care. Sure. Well, let's go. Let's do it. Couldn't get a stair chair in the house. Like, it was just like, there was maybe this much space between stuff. Walk her out, get her on the stretcher. Right? Walks with no problem. No support, nothing. Get her in the back of the truck. Start going. About 10 minutes into the ride, I'm like, I'm just going to do another check. Because she's like, her hand's doing this still. I'm like, can you move your hand? She's like, no. I'm like, can you make a fist? She's like, no. Can you pick it up? No. Can you feel me touching your feet? She goes, I can't really feel it on the left side, which her left hand was affected. And I was like, okay, let me call in a note, because she went from an S-Lambda 1 to an S-Lambda 4. And I was like, curses. So we get to the hospital, and I was like, because so like the note, of course, didn't go through, because I'm standing there like with the radio, like pointing the antenna out the window, praying that it'll work. So they gave like a really bad notification to 35, and we get there. They're like, "Are you the stroke?" We're like, "We're the stroke." Okay, what's going on? I'm like, she's got some progressive neurological deficits on the left side. She's describing the same symptoms as when her first stroke happened. Like, oh, go right to CT. Okay. So we get to CT, and there's someone in the CT scanner. So we're just standing like boobs out in the hallway, like, well, this is a nice spot. The doc, like 3 docs came over and they asked her all the same exact questions. And I was like, all right. And she's like looking at like, why y'all keep asking me the same damn questions? I don't know if she was actually having a stroke, because she only got into the scanner like when we were leaving. But I'm pretty sure, pretty confident, they're like already drawing up TPA for her. So then we had another guy, and this is going to be a look, like, you guys have probably already seen it, but there is a look that patients have when they have certain medical problems. So we walk in for the unconscious, and this guy's like, and I'm like, oh, that's a brain bleed. Like, just textbook, like totally brain bleed. And they're like, oh yeah, no, he was complaining of a severe headache and then just became unresponsive. And I was like, brain bleed. And I'm looking at him, he's breathing like crap, and I go to my partner, I'm like, you thinking what I'm thinking? He's like, I don't know, what are you thinking? And I'm like, oh, all right, this is the first time you and I have worked together. We're gonna tube him. And he's like, oh, yeah, no, definitely. I'm like, I'll be back. So I get Hansard on the phone, and he's like, oh, well, yeah, no, definitely, you want to tube him? I'm like, thank you. He's like, well, so it's a different dosage for etomidate for men versus, I'm like, dude, I don't care, what dose am I giving? Like, what? Like, why are we chatting right now? So go to tube the guy. He had the world's smallest mouth. And then he became a geyser of soup. He must have had soup for dinner. It was gross. So didn't end up actually getting tubed till we got to the hospital. And then the respiratory therapist went and put like an 8 in this dude. And I was like, you're just showing off now. And he looks up. He's like, where you been? And I'm like, bro, I left 2 years ago. I'm back now. And he's like, you just know. I'm like, you just noticed. So.
Wait, is this at Jamaica? You went to Jamaica?
Yeah, we went to Jamaica. Rothman was our backup.
Oh.
I was like, this is what happened. I go, 5-1 Victor, can I get BLS for hands? I didn't even let go of the button. 4-6 Charlie put me on their back, and I was like, dude.
Yep.
Like, let me let go of the button first. He goes, we were already moving. I was like, how were you moving already? I didn't even ask for anything yet. So that was fun. Just big old pile of soup. So yeah, so pro tip, if you're going to tube someone, make sure you have a suction canister. We did not have a suction canister. That was my bad. That's just rusty. Did not have a suction canister, so it was just not pretty. Also, make sure that you have a blade that you are comfortable with. I know you guys have probably all done most of your practice on the Mac. However, when you can't get a tube with a Mac, you go to a Miller. So why not just start with something you know you'll have success on? I'm a Miller person, like one of 2 who work at Jamaica, so. All right, Joni, you warm? You ready?
Yep.
Do some finger yoga? All right, cool. So good news. This was written by Scott, who actually writes a decent test question, much better than the JB Learning nonsense that they have. So we're already off to a better start, because these are what we like to call "quote unquote" so what questions. Like, it doesn't matter. Like, the information needs to matter. I think either Zach got a job or kicked his partner out of the truck. Bye, Zach. So, with that being said, different types of. All right, hold on. Let me specify. Know the names of the different brain bleeds, like the location, based on their location, right? So, like, if a bleed is between the meninges and the bone versus the meninges and the brain. Do all patients having an MI have chest pain? If the heart has increased oxygen demand, how does it supply itself with more oxygen? Understand the definition of disentanglement. Not an entanglement, a disentanglement. What stimulates a healthy person's respiratory drive? If after you have performed a primary survey on a patient who is complaining of shortness of breath, you determine that there is tachycardia and a distended liver, what's your next step for treating this patient? Does the brain regenerate itself? Signs. All right, and this is another thing that I noticed that you guys, like, make a note somewhere. Read your questions carefully. There were a number of questions that there was a large number of people who got wrong on this last exam simply because you didn't read the question carefully and you got snookered into picking the wrong choice, like the one that, like, your brain filled in the gaps and the gaps were wrong. So make sure that you read the question carefully. For example, What are some signs and symptoms that you would not expect to see in a patient in hypovolemic shock? If you have a patient who has a shortened leg on one side, an elderly patient with a shortened leg on one side, status post a fall, what should you suspect? Review your legal protections as an EMT. Specifically, the difference between like the Good Samaritan Act and the part of law that protects an EMT. What would be considered the highest triage priority? If the heart is chronically unable to pump effectively, resulting in blood or fluid ending up from whence it came, what medical condition are you dealing with? Where are your blades? Intubation, right? Mack versus Miller, where are they placed? What's the appropriate placement for those? Patient who has suffered a 10-foot fall with a relatively stable vital signs but is restless and agitated, what injuries should you suspect? Acid base. That's all I'm going to say, acid base. Know what the normal pH level is, and make sure that you review and or memorize the acid base chart, right? So like the metabolic respiratory metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Make sure you have those down cold. And by down cold, I mean just memorize the chart. And then when you get to the test, because I'm going to have you do this on the state as well, just write it down. Okay? You're going to do a info dump. What type of shock is a vasopressor inappropriate for? Inappropriate for. Joni, we just talked about this regarding lactic acid and aerobic, anaerobic. If a patient is in a low cardiac state, what kind of metabolism are they in?
Metabolic acid.
Say it again.
Metabolic acidotic state.
What's the name of the acid?
Go
back to the rhabdo scenario.
Myoglobin?
No, the myoglobin is just a protein. What's the acid?
Like lactic acid? Oh, okay.
And lactic acid is produced during what kind of muscle metabolism?
Anaerobic.
Anaerobic.
Joe has entered the chat.
Joe,
Thank you.
Zach, are you on a job or are you just facilitating? Oh, he froze. Under mental health law, what can you do to a patient who is considered a threat to themselves or others? What do you do if there's a limb presentation during childbirth? Crying is not the appropriate answer. Cursing, also not the appropriate answer. What is the definition of potentiation in pharmacology? If you are palpating a blood pressure, what are you palpating exactly? Like, what numbers are you getting? Oh, one math question. Don't forget what your formulas are. Volume over time times drip set. Dose on hand, or sorry, desired dose over dose on hand times your drip set. Make sure you remember those. If that's the case, if you have a, if you were asked to administer 100 milliliters in 30 minutes using a macro drip, what would your rate be? And don't forget that there's more than one type of macro drip. If you find a patient, an elderly patient, status post fall, with an inverted knee and foot that is unable to straighten their leg, what kind of injury do you suspect? In is out, and
Hip
out
dislocation?
is in. In is out, and out is in. Perfect. I'm gonna give you this one because I don't know. People experiencing early signs and symptoms of a heart attack will often deny that they are having a heart attack. Sidebar, went to the liquor store today for the BYOB version of this class and ended up buying like an entire case of wine and was like, I did not plan this well. If a patient is burned in a confined area, what are some significant considerations that you must take into account? BLS question. If you attempt to ventilate a patient, an unconscious adult, and the airway and the ventilation does not go in, what should you do? Oh, sorry, every position. Complications resulting from chest compressions. So they're CPR chest compressions. This is a one test where you may see all of the above as an option. Do not be alarmed by that. Patients with COPD lose the normal stimulus to drive, or to breathe, not to drive, just to breathe, the normal breathing drive. What does that stimulus become? Mind you, you should understand the mechanics behind it in terms of, is it high PO2, high PCO2, low PO2, high PCO2?
They use the hypoxic drive, no?
Yes, and this is what I'm saying. Use that. What is hypoxic drive in medically terms? Is it
hypoxic drive would be where you have an elevated CO level, and your body switches over. So if you get into a situation, Joni and I have had this discussion, you give them too much oxygen, this will depress their respirations.
Yes.
We're close on that? Yes.
No, you're accurate on that.
Okay.
Is that driven by a high or low PO2 or PCO2? Hello.
Well, if it's stimulated now by a hypoxic drive, and giving them more oxygen would reduce their respirations, then technically would it not be stimulated then by a lowered PCO2?
Not C.
Higher.
Oh, I'm sorry, PO2, lower PO2.
Low PO2.
Okay, low.
Right? So like this is why, because you just explained very nicely that when you give a COPD patient oxygen, right? They don't have a low PO2, so that's why their respiratory drive is suppressed. We good? We good on that? Ow, Boże. All right, cool. 29. How long? Or sorry. If you have a patient who has drowned in chilly water, should you perform CPR? What breath sound is associated with laryngeal or tracheal obstructions? Child victim, ineffective cough, high-pitched inhalation noises, and increased respiratory difficulty is usually a sign of what in a kid, in a child? What is the most common cause of cardiac arrest in children? Best indicator of adequate brain circulation. Scenario question. What treatments should you do for a patient in acute respiratory distress, ANO3, stable blood pressure, respiratory rate of 30 with pursed lip breathing, pedal edema, and wheezing in all fields?
Sanford Avenue and Union Street, 52 George to the injury.
Mike, you got your mic on with your radio on.
Wait, Mike, where are you going? Mike,
Yeah.
what unit are you on?
Can I throw out their CPAP?
Not going anywhere yet.
You could. It's not an option.
Okay.
So-
In that answer. Okay,
Yeah,
got
so
it.
it's not even an option at all. So like, what would appropriate treatment for this patient be?
Oh, okay. Pharmacology treatment?
No, in general, like start to
Oh,
finish.
okay.
Yeah,
Oh,
yeah,
okay,
yeah.
got it. Okay, got it. Like the list of priority treatments. Got it. All right.
When would you consider intubation for a patient complaining of shortness of breath? Like where, and I know that this is like one of those like kind of subjective determinations, but like if you are treating a patient who is severely short of breath, at what point do you go, it's time, get to the tube?
And they have the impending look of doom on their face.
Doom, good. Go with doom. I'm gonna tell you a quick story, patient care story, to tie this in nicely. Once upon a time, got called to back up a Northwell unit for a lady who was having severe respiratory distress. When we got on the truck, she's looking like this. turns out she has COPD, but she also had lung cancer, and they took one lung out. So now she's got one COPD lung. Ended up tubing her with a 6.5 as we're flying down Jamaica Avenue. And then the moral of the story was the respiratory therapist is like, why didn't you put in a 7? And I was like, bro, she's like this big. Like, 6.5 was appropriate. You go for a full size and then you go down. I'm like, nah. You get one shot. You M&M this. Full blown. All right. During ventricular diastole, which heart valves are open and which heart valves are closed?
Nicole,
Yes.
I got a quick question for you. So because I wasn't here and this question may have been asked. Can we anticipate that these questions in the midterm will be taken from earlier exams, like verbatim, or no, it will be completely new questions?
These are 100% Scott Holiday written questions.
Oh, fantastic.
Which, no, actually is a very good thing.
Okay.
Because they're straight to the point, simple language.
Okay.
They're not really trying to jam you up like a la National Registry, where they're like,
Okay.
you roll up on scene and things are on fire and you have lost your partner. What's the best treatment for this patient?
Okay.
Yeah, these
Bunch
are
of distractors.
yeah, the distractors are like reasonable.
So was this a decision that was made in the past, or was this something that came on like quite recently today after other discussion?
Not today. It was made prior to
Okay.
today's discussion. However, I don't know where I was going with that. It's honestly, it's probably a better thing that this is your midterm, because I think that these are more fair questions than the JB Learning ones, which are convoluted, poorly written, and frankly just rubbish.
So, okay, got it. Thank you.
You're welcome. If you have a patient, that's my finger you're chewing. Who is coughing up bright red frothy blood, what would you suspect if CHF and APE was not an option? What happens when you stimulate the vagus nerve? And if you put old people die on the toilet, you're not wrong. Another hypoxic drive question that was actually the lead-in to discussing PO2, PCO2, and what happens when you put a COPD patient on oxygen. In the C portion of your primary assessment of a male who is shot in the right upper quadrant and chest area, who is hypovolemic, tachycardic, and has diminished lung sounds, what are you going to do for C? Alpha receptors, beta receptors. Okay, so remember A, B, C, D. Alphas constrict, betas dilate. So a beta blocker will prevent dilation. Mike, where are you going? Mike, go save the day.
I'm not going anywhere. I'm just watching someone almost back into me.
Lord. Signs, symptoms of heat stroke. During the patient interview, what part do you obtain the patient complaint? Why do patients with acute abdominal pain stay very, very still? If you are splinting a hand, what is the best way to do so? BLS question. Do you want knife hand? Or do you want claw hand? Knife hand, claw hand. Misfeasance, definition of. No blood flow through the heart. So if, like, at any point in time, someone asks you, is the blood going that is exiting the left ventricle oxygenated or deoxygenated? You should know. Okay? Essential. All right? You should know at every single point in the body, right? So if I tell you that you have blood in the femoral artery, is it oxygenated or deoxygenated? Okay, so make sure that you know you can trace the flow of the oxygenated and deoxygenated blood through the body. Hello. Don't. I'm gonna give you the answer to this one too, because I don't like this one at all. Which of the following is a primary responsibility of an advanced EMT? Maintaining medical knowledge. Ah, dog breath. Hi, what's up? Can you get down? Get down. Get down. Get down. Thank you. Laws of emancipation. What are the specifics? Like what in what scenarios is a child considered emancipated? Get your paw off the table. What are you doing? Review the START triage system. So you should be able to know, like, which patient's considered deceased, which patient's considered immediate, which patient's considered delayed or minor based on how they're presenting. I'm gonna give you this one too. I mean, I'm sure someone's gonna get this right, but you have a patient who's got AIDS. You fear for your safety, so therefore, your patient has unstable vital signs. You fear for your safety, decide not to treat or transport. Is this an appropriate action? Chief concern of ruptured ectopic pregnancy. I know the answer is not who's the baby daddy. Signs and symptoms of preeclampsia. Your agency's policy states that you must check the ambulance equipment at the beginning of your shift. Clearly, no one's worked in New York City. You start at 7 a.m. and decide to go get a coffee and then wait an hour before checking the ambulance. What is this considered? Unprofessional. Incident command system. Who is in charge of overall scene eval? Delayed stress reactions to a stressful incident is considered what? If you have a patient complaining of nausea, vomiting, and is yellow tinged, what is the most likely cause of his complaint? What are the techniques used in a head-to-toe evaluation? Best way to say this, high pass gas. Remember that from BLS back in the day for your breathing stage? That sums up about most of the things that you probably want to know for that question. When will you control severe bleeding for a trauma patient? And I disagree with the answer to this, but it's after airway and breathing. How does epi correct hives associated with anaphylaxis? What are the two main pharmacological classes of sedative hypnotics? You tube somebody and you ain't got no chest rise. What problem do you have? Vomit geyser
Pneumo.
is probably it. Zach, are you talking? Because you're muted. What is the chemical that keeps the alveoli from collapsing? Contraindications to nasotracheal intubation. Zach, why did your eyes get so big and scared?
What happened?
I don't know. You look terrified for a moment there. You okay?
Yeah, I'm very terrified. I'm working with these two morons. Ah!
No, just one moron.
What carries the majority of oxygen in the blood? Medical patient. What is the position that you're going to use prior to intubation? What do baroreceptors do? What ion is what's being measured in regards to your acid-base balance? Understand the concepts of diffusion and how fluid moves across a cell in the presence of a hypertonic, hypotonic, and an isotonic solution. Okay? If you have to draw a picture for this, totally okay, right? So like if you draw a picture that you have like a cell and there's like a lot of like salt inside the cell, which make the cell hypertonic, how would the fluid move? Or how would the ions inside that cell move? Which drug would not be used to treat ventricular dysrhythmia? If y'all don't get this 100% correct, the moon. Drug math question. Simple one. Basic math. You are ordered to administer an IV bolus of lidocaine for a 176-pound patient. It's a mg per kg dose, and you have a 5 ml syringe that has 100 milligrams of lidocaine in it. You're going to tell them how many milliliters you are administering. What are the angles for injection for a IM and S sub Q injections, medication administration? Mag drip. How does one set up a mag drip? And what's your rate using a micro drop? I'm going to give you this one too because I know it's marked wrong. Because, hold on. Yep, nope. I've corrected this question in the past and it has not been corrected. If you have a physician who has written a prescription for ibuprofen 0.5 grams TID and the tablets are 250 milligrams, how many tablets must be taken to equal the prescribed dose? What's the difference between, or know the actions of, and the general actions of sympathomimetics, sympatholytics, parasympatholytics, and parasympathomimetics. That was a mouthful. Dog. Hello. Complications of major burns. Burns caused by a flow of electrons. Understand what your like burn levels are, right? So like if it's a full thickness or first degree burn, what depth of skin does that go through? Second degree / partial thickness, third degree / full thickness, like where are you in terms of damage to the skin? Main characteristic of a second degree burn. Rule of nines. One rule of nines question so far. 2 rule of nines questions. 1 adult and 1 peds. Know your rule of nines. Biggest concern for a patient who has been hit with superheated steam. Differences between an incision and a laceration, and the weapons that could cause them. If a tourniquet is in place, the blood distal to the tourniquet will be what exactly? Like, if you had to describe it. A la compartment syndrome. What do you do with an amputated toe? And if you say bring it home, no, but I give you 10 points. How does electrical current travel through the body? What are the structures of the upper airway versus the structures of the lower airway? Know the difference between the two. Know the definition of respiration versus the definition of ventilation. Again, know the path of oxygenated and deoxygenated blood in the body. Where is oxygen exchange occur in the lungs? Another COPD question that discusses PaO2 and PaCO2. So make sure you know those two. Signs and symptoms of respiratory distress. Tactile fremitus. That's all I got for you on that one. Abnormal breath sounds caused by narrowing of the airways is called what? If you have an unconscious patient with snoring respirations, what should you evaluate them for? Rapidly deteriorating mental status in a patient complaining of chest pain and vomiting with a normal upper air or normal airway. Know the anatomical descriptors of the heart, a la base and apex, and the epicardium, myocardium, pericardium, and endocardium. That's like 3 questions right there. Another, know the flow of the heart. That's 3 or 4 questions now, right? Know the flow of blood that goes through the heart and the body. Where do the coronary arteries originate? Know your definitions of preload, afterload, stroke volume, and cardiac output, as well as Starling's law of the heart. I love that guy. He's got a good law and a good name. Again, another question about one of the definitions of those 5 things. Another question. That's now 4 questions on those 5 things I just talked about. How does the sympathetic nervous system innervate the heart? Chemical neurotransmitters for the sympathetic nervous system and the parasympathetic nervous system. If a nerve is stimulated through the release of its neurotransmitter, what will happen? How would you treat a patient with a pulse of 100/70, pulse of 180 and weak, and complaining of severe substernal chest pain? What is your treatment modality? Acid-base imbalances. Know them cold, right? So like what numbers would, like pH and PCO2 and HCO3, what numbers consist of which imbalance, okay? You can probably get the majority of this question. You can narrow it down to a 50-50 just by knowing your pHs. Know the definitions of chronotropy, dronotropy, inotropy, and automaticity, as well as depolarization and repolarization. That's 3 questions. Where is the normal pacemaker of the heart located? During depolarization, how do ions move? The ions inside of a myocardial heart cell. What's happening during depolarization? Another question about the dipole-repole, action potential, automaticity. What does lead 2 look at? So you know your Einthoven's triangle, right? So like you have lead 1, lead 2, and like from like shoulder to shoulder, shoulder to foot, right? Know which direction it's looking at. There's an EKG question. Identify your rhythm. Make sure you know your rhythms, y'all. Because there's another one right after it. During disease states, this portion of an EKG may be elevated or depressed. Know your partial refractory period, or your relative refractory period versus your absolute refractory period. Definitions of. This might get screwy. So they give you an EKG and then ask you to provide a best diagnosis. It looks like the EKG is not here in my little printout. So make sure that you know what your leads are, right? Elevations in certain leads. Is it anterior, septal, lateral, inferior? Okay, know which is which.
Nicole, quick question. So we were talking about this the other day. The three things that we're looking for in elevations and or depressions are ischemia, injury, and infarct. Okay, an infarct is death of tissue. Ischemia is just getting short on oxygen, and injury is actual like in between.
No,
Yes or
so
no?
it's injury. Sorry,
Okay.
injury, ischemia, infarct, and
Okay.
like we're not too bad to worse. So like if you have a patient who has a history of stable angina and like I'm having some chest pain, well, did you take your nitro? No, you might see injury. Okay, so like you give them the nitro, it gets completely better. Ischemia is when you have a patient who has those elevations, right?
Okay.
Injury, you'll probably see depressions. In ischemia, you'll have elevations. In infarct, you have those pathological Q waves, right? So the damage is done. It's never going to reheal. The EKG starts to come back to sort of looking normal, but you might have a patient with like a left bundle branch or pathological Q waves or some other kind of funkiness in their EKG that would indicate that some sort of event has happened.
Okay.
If you have a, hold on, I missed a bunch. Please roll with the punches because vagus is misspelled as the vague nerve, and I'm pretty sure if I go back and ask them to correct that, I might actually get fired. It was a rough day today, y'all. Stimulation of the vagus nerve causes what?
Rough for who, Nicole?
Altogether, I don't think you understand the amount of empathetic stress I feel for all y'all.
Oh no, I get
Hold
it.
on, wait,
And
no, you don't. This is my current bottle of wine. I started this a little while ago.
I didn't even read the email that Scott sent me this morning because it was so long, and I just figured it's not worth it.
He
Not
needs
even gonna
like
bother.
he needs a TLDR at the bottom of his eye of his emails.
I just waited for Zach to tell me he got his email, which said it's all resolved.
Yeah, I'm glad it's resolved. Can you get down, please? Get down. Get down. Thank you. More questions about lactic acid. Chest pain associated with angina is caused by what? Chest pain with a decreased level of consciousness could indicate interruption of blood flow to the brain caused by what pathological problem? Know your pharmacological effects of dopamine doses, right? So like you have your 2 to 5, your 5 to 10, and then your 10 plus, right? Ranges. So they all do different things and they all affect different body parts or receptors, I guess is actually more accurate.
Tim was actually talking about that. He said that the higher doses is more of an alpha, and then the lower doses is a beta.
That's like literally the answer.
So high dose vasopressor, low dose is cardiac contractility, right?
Yes. So like there's like so it's like you have alpha, beta, and dopaminergic ranges for dopamine. Just familiarize yourself with it. Not that we're going to have dopamine in our protocols for much longer, but unfortunately you do need to learn these things. Which is really more of like a, I had to learn it, so you have to learn it. Anyway, moving on. What? Does syncope cause pulmonary edema? Irregular pulses in a possible cardiac patient is a sign of what? Don't think too much into this one. Very simple answer. Left ventricular failure frequently causes what? JVD in the cardiac patient is an indicator of what? Hello. Go ahead.
Cardiac tamponade?
Not that kind of cardiac patient.
Okay.
Like think more of like a CHF patient. A from whence it came kind of vibe. Because from whence it came is back pressure. Another question about back pressure. If there's systemic venous back pressure, what does that cause? What does a BRUIT, B-R-U-I-T, indicate? Management for angina pectoris. Pharmacological management of angina pectoris. Pharmacological management for pulmonary edema. Pharmacological management of cardiogenic shock. These are things you can also look at your protocols for. First line treatment for VFib. Easiest and most important therapeutic intervention to ensure appropriate acid-base balance during a cardiac arrest.
Bicarb. No?
BLS.
Bicarb?
Full-blown BLS.
Ventilations.
Remember, BLS before ALS. Because you will get jammed up by pharmacological options here. Ballooning of an arterial wall is called what? Hypotensive patient complaining of back and flank pain with a pulsatile mass is most likely experiencing what? Know your differences between a sympathomimetic, a sympatholytic, and hold on. Sympathomimetic, sympatholytic, parasympathomimetic, and a parasympatholytic, and their uses in treating cardiac issues, a la bradycardias. First line med for SVT, not adenosine. Actually, I really don't like this one at all.
Bagel maneuvers?
No, pharmacological. No, I don't like this question either. The answer for this one's diltiazem. I don't like this at all. I'm gonna circle this one.
What did that increase contractility?
No,
in
it says
SVT?
it's actually the opposite. It's a calcium channel blocker.
So you're talking about narrow, stable SVT?
Unstable.
Unstable. Thank you. Okay. Thank
You're
you.
welcome.
So, and you don't like it. Why?
You have unstable SVT. You shouldn't be treating it with
Should
medication.
be with cardioversion. Got it.
So then if you knock it down to, okay, well, cardioversion is not an option. Now choose between adenosine and diltiazem.
You're going to go with adenosine because you're not thinking narrow or wide.
You're not thinking,
Yeah.
oh, maybe it's an AFib. Like,
Right.
Medication used in VFib, asystole, and PEA that acts on alpha and beta receptors. I'm not even giving you this one. The answer is literally in the question. Narcotic analgesics. reasons digitalis may be prescribed. Know the ending for what a beta blocker is. Like carvedilol, metoprolol, propranolol. You need to know the endings for beta blockers and calcium channel blockers, etc. Information that can be obtained from a single lead of an EKG. Normal PR interval length. Normal QRS interval length. When a branch of a conduction pathway is blocked in the heart, a depolarization wave may travel backward through the branch to its origin, causing stimulation of the tissue. This can result in the development of rapid rhythms. This process is called what? I also don't like this one because that's not the right answer.
Isn't it re-entry SVT?
It should be. That's what the answer should be, but it's listed here as retrograde. So stand by on that one. Let me see if I can get that answer corrected because it's supposed to be, it should be re-entry.
Okay, so, and again, without harping on this too much, this was a Scott Holiday production. Is he still working on this draft, or is this supposed to be the final draft?
This is the final draft. I don't know if he might have just clicked the wrong answer on that because they're right on top of each other.
Got it.
So like that's only, and 2 versus 9 is a huge difference. What is a common airway complication of anaphylaxis? Primary drug used to treat an allergic reaction. An allergic reaction, not anaphylaxis. And this goes back to making sure you read the question carefully. So if you look at your protocol, if you have a patient who's having an allergic reaction, what medications do you give versus a patient who is having an anaphylactic reaction? Okay?
Benadryl versus Epi, right?
Exactly.
Or diphenhydramine, otherwise known as diphenhydramine.
Yes, the artist formerly known as diphenhydramine.
Yes.
What does diphenhydramine do? Especially in anaphylaxis, not just like make you sleepy. What is like the definition of diabetes mellitus? Type 1. Know the difference between type 1 and type 2 diabetes. Yep. In a patient with diabetes, when the glucose starts to go into the urine and takes water with it, what is that called? Understand the processes of ketoacidosis and hyperosmotic non-ketoacidosis. Also understand how hypoglycemia can happen in a diabetic, like the main causes. Differences between a hypoglycemic and a hyperglycemic emergency, as in onset, presentation, etc. That's 2 questions. Kussmaul's. Describe. And if y'all don't get this one right, what is your emergency intervention for an unconscious hypoglycemic patient? Major organ of the GI tract. Go ahead, Joni, sorry.
Nothing, I was gonna say orange juice.
Had a diabetic patient once. A little elderly couple, lived in a basement apartment, like very clearly had like very little money on a fixed income. Husband was diabetic, and he was just awake enough where like he could eat. So we're like, ma'am, can you make him a sandwich? She's like, yeah, sure, absolutely. I don't want him to go to the hospital. I'm like, we don't want him to have to go to the hospital either. Makes him a sandwich. He eats it. Doesn't get much better. And I'm like, oh, which, like, can you make him another PB&J? She's like, yeah, absolutely. So I kind of pop out into the kitchen while she's doing it. And there's, like, no food in their fridge. She goes, yeah, no, like, we didn't get a chance to go to the grocery store this week. He wasn't feeling well. Okay. She goes, yeah, we were planning on going today. And he went kind of whoopy. I look at what she's making this peanut butter and jelly sandwich with, and it's sugar-free jelly. And I'm like, this is why it's not working. So close. I was like, God, you got like any candy or something in this house? You need to feed him sugar. When you're really good at being a diabetic. Y'all should get that one. That's not even like a BLS question. That's like a second grade question. You'll be okay. Like grade 2, learning about the body. Acute abdominal pain that begins around the umbilicus and then migrates to the right lower quadrant. Define hematemesis. Vomiting
You mean
blood.
like vomiting blood?
There's certain words I can't do even when I'm not drinking wine.
Was that hemoptimus?
No,
No.
Hematemesis. Hematemesis.
hemoptysis is coughing up blood.
Okay, got it. All right.
Hematemesis.
I just wanted you to say it again.
What medication do we use to treat insecticide poisoning? Upper GI hemorrhages, main causes of upper GI hemorrhages. Diseases transmitted by respiratory secretions. Pulsatile abdominal masses. What does that indicate? There's 2 questions on that one so far. Causes of syncope in an elderly patient, and by elderly, it's over 60 in this question. So apologies for people who are 60 and don't feel elderly. Normal physiological effects caused by exposure to high environmental temperature and humidity. Define chronic renal failure. Major complication of peritoneal dialysis. Define testicular torsion. At best source of information about signs and symptoms, or by symptoms experienced by an 8-year-old. I'm gonna give you this one because I don't like it. It's just gonna be an argument. In your 4-month-old patient, the anterior fontanelle is bulging. This is considered normal for this age. Peak incidence of SIDS. What age group? Common cause of seizures in children under 5. Correct management of a seizing child. How do I say this one? Meningitis is frequently a consequence of what other infectious processes? Yellow discharge from the penis and burning urination. Which STD do you have? Best method to prevent accidents from a contaminated needle, like accidental needle sticks. In gastroenteritis, when should you do IV fluid placement? Functions of the placenta. What protects the fetus from blunt trauma? Know the difference between placenta previa, abruption, eclampsia, preeclampsia. Why do you avoid putting a pregnant lady in the supine position? A very pregnant lady, not like a little pregnant, very pregnant lady. What is meconium a sign of? Most important indicator of fetal distress or neonatal distress. Know the normal vital sign ranges for children, pediatrics. Common causes of behavioral emergencies in the elderly. What is the best way to calm and relax a behavioral emergency patient? When should you remove bystanders from a behavioral emergency patient scene? If you have a patient who has overdosed on diazepam, how do I phrase this? Would their PCO2 be high or low? Would their pH be high or low? And which acid-base disorder would they be experiencing? Principal intracellular cation. Alpha constricts, beta dilates. And where is the majority of all of your body water? That's it. 'Tis the midterm. There are 3 of them that I need to review with him and be like, I'm not sure about these. But aside from that, that's going to take you pretty far, I hope.
So, okay. So Nicole, those were the 200 questions.
Mm-hmm.
So, all right. So basically we'll get to work. For those that are still on, Joni, Zach, everybody else, maybe about 2 weeks or so, before we come back to you, Nicole, just give you what we have.
Sounds good.
And then we can, we'll work out a schedule. We're going to do a regular review amongst ourselves on this once we get it all hammered out.
Okay. And yeah, in about mid-December, I want you guys to send it to me so I can see if your review is on point, and if it's not, I will refine it so that you guys can study more appropriately. I will also continue to do like scenario stuff on a weekly basis with you guys, because I think that will hopefully help you during rotations as well. If anyone has an interesting call and that they want to kind of do, please send it to me so that we can use it for one of these scenarios.
Okay.
All right.
Can't wait to see you Tuesday.
All right, guys. See you.
Thank you.
I'll see you next week. No one's writing Monday, right? The 16th?
I'm writing Sunday.
Boo. All right, I just got a Victor 2 on Monday, so maybe I'll see you guys around. Maybe not. December is up. I bid for a couple of shifts, so I'll let you know if I get anything. But other than that, have a good night, guys.
Check my email.
No, what's your email?
Thank you, Nicole.
All right, guys.
Thank you,
Thanks,
Nicole.
Nicole.
Good night.
You're welcome. Good night.
Good night.